Number two. Millie, are you still with us?
I think Millie went mute.
Okay. I hope that I know how to prepare that. You know how to share your screen and everything else, I'm sure.
I know how to share my screen.
Good.
We're ready to go, Dr. Garcia.
Okay. Good afternoon, and it's a great pleasure for me today to introduce someone who is truly a specialist in her field, and in addition to that, a great person, a great physician, very smart, question producer for the ABIM. We miss her very much. Marie Dennis Gerhard-Herman is a cardiovascular medicine specialist at the Brigham and Women's. She's associate professor of medicine at Harvard Medical School. She graduated from Northwestern, where she completed later her residency program in internal medicine at the Boston City Hospital. And she completed finally her cardiovascular medicine and vascular medicine fellowships at Brigham and Women. And she's board certified in cardiovascular disease. She was a member of the ABIM board until very recently, where she shared her unique knowledge with us. It was a pleasure to have her, and we learned quite a deal from her. She had many clinical interests, including obviously the diagnosis and management of deep vein thrombosis, general vascular medicine, and the Hutchinson-Gilford progeria syndrome, and she has authored over 75 peer-reviewed journals in those topics. And currently, she has research that is supported by the NIH and the Progeria Research Foundation. She will be talking to us about a topic of interest, which is a diagnosis of deep vein thrombosis in the COVID-19 era in the population. I guess a new challenge that we have to deal with in our specialty. Marie?
Thank you very much. So it's going to be actually not deep vein thrombosis, but PAD. I think, but we'll touch a little bit on the thrombosis issues that are involved in SARS-CoV as well. I have absolutely no disclosures, which is actually quite a struggle for me to continue to do, but I'm proud of that. I think that I want to start by talking about how to advance my computer. There we go. The path of this talk. So this talk is going to talk about PAD in general, actually. How you define it by the Ankle-Brachial Index, how it's and where it's done and how it's interpreted. And the fact that we need to broaden our symptom assessment. Any muscle discomfort with exercise. There's a concept of masked PAD because many of our patients don't walk. And specifically, we'll talk a little bit about dealing with rest symptoms, rest discomfort, and limb ischemia. It's an important background to look at some of the unique observations in PAD with the COVID-19. And it's multifactorial. The thrombosis in the venous system has been overwhelming, as you all probably recognize as well, both peripheral and pulmonary. But the arterial problems have been quite difficult, including digital vasospasm with COVID blue toes, differences in populations, the acute arterial thrombotic events, and actually the subacute arterial thrombotic events that also seem to be increasing the risk of amputation, and a little bit about how we're going to move forward with research in this area. So atherosclerosis is a systemic and a progressive process. So we think about, by the time we're 18, people often have fatty streaks building up in their arteries. the atherosclerosis accumulates, we get occlusive disease, and we're used to recognizing angina with occlusion of adequate supply to the cardiac muscle with exercise. Similarly, people think about claudication, not supplying enough blood to the leg with exercise. It's under-recognized if we use the conventional Rose claudication questionnaire. So we will hammer on that a little bit. And the other concept is that there can be a rapid step up in the arterial disease if there's acute plaque rupture. We're used to recognizing that with myocardial infarction, but it's definitely going to play a role in critical leg ischemia and may actually be playing a role in what we're seeing with the increased amputations in the SARS-CoV-2. So I think just for the cardiology audience, it's important to point out there's a little bit of a difference in definitions here. So when we think of coronary artery disease, we think about it being present when there's atherosclerotic plaque on the coronary arteries, so an anatomic definition. We do have functional testing, but our definition really requires on the anatomic presence of plaque. In contrast with PAD, it's defined by a drop in arterial pressure across a stenosis, not just by the presence of plaque. So it's actually a physiology requirement for the diagnosis. In this talk, we're going to be talking specifically about atherosclerosis in terms of PAD. And the take home for everybody's t-shirts is PAD is an ABI less than 0.90. So this is one of my colleagues actually doing an ABI in the office. ABIs are commonly done in the vascular lab, but it's a very simple setup. It's the same size cuffs that we're used to typically in the arms, usually fit a person's ankle. And you're going to have the patient supine and check systolic pressures in the brachial, posterior tibial, and dorsalis pedis pulses. And take the higher of the two and put it over the highest of the two arm pressures. So the highest pressure here is going to reflect central aortic pressure. And then you divide ankle over brachial to get the ABI. So 1 is normal, 0.75 is less than 0.90 that I just told you, so it's abnormal. And I can't believe I kept this picture in because this is exactly what I was just doing in clinic. I spend way too much time drawing for my patients. But it's not easy for people to use a Doppler in the office. It's not quick either. So years ago now, Josh Beckman and I looked at ABI by Doppler and ABI just by using the automatic cuffs that we have in the clinic areas. And we found out that you got a very reliable ABI with appropriately sized cuffs using the oscillometric cuffs in the clinic area. So it gave you an easy way to get an ABI in the office. So I said that this is defined by that number, the ABI number, but who do we test for this? How do we recognize who has PAD? So history and physical examination are important. The Rose claudication questionnaire is a little too tight, misses many people. It's more broad to think about any non-joint related pain in the muscles of the lower extremity with activity that goes away with rest. It could be anything. It's just in the muscles with activity, goes away with rest. Impaired walking function, just asking people how much walking they do. They may have noticed over time that they only walk a block at a time. Ischemic rest pain, cold, painful extremities is unusual, but obviously important to recognize. Physical exam is really going to depend on actually, as one of my partners used to say, just taking the shoes and socks off, actually doing a lower extremity pulse exam. In a lot of people, there's difficulty with the dorsalis pedis, but if the posterior tibial pulse is there, everyone should be able to feel it. Listening for vascular bruits. Typically, we only do that after they've been in the cath lab. And physical exam that shows a dry, non-healing lower extremity wound would be very suggestive for PAD. And if there's inadequate flow, if you lift the leg up, you won't have the effect of gravity, so you're gonna have a pale leg. And then if you hang the leg down, it's going to get red. Also suggests pretty significant PAD. Typically, we're going to suspect it in people over 65, people younger than that, 50 to 64, who have risk factors, diabetes, cigarette smoking, high cholesterol, and definitely with diabetes, even at ages less than 50. Anybody with a ton of atherosclerosis elsewhere is likely to have it in their legs as well. So we have a history and physical exam that's suggestive of PAD. We can do an ABI. You can do the ABI in the office. You can send them to your vascular lab, either way. If the ABI is less than 0.90, you have PAD. If you can't compress the vessels, you're going to do a toe brachial index, which I'll talk about in a minute. But if you clinically think they have PAD and you're getting a normal ABI, you actually want to put them on a treadmill to see that with increased demand of the muscles in the legs, does their ABI drop? Similar to thinking about a cardiac stress test. And all the other testing that we do is really safe for those people who have PAD, but it's so bad that it's limiting their lifestyle. So then we're going to look at anatomy to think about revascularization options. So it's going to be a big spectrum. Normal is going to be above 0.9, but to be honest, stone cold normal should really be over here at about 1.2. The lower you get, the more occlusive disease you have, the lower you have for your pressure beyond the stenosis. High ones are going to be called non-compressible. In that case, we're going to do a toe brachial index. Fingers and toes get cold when it's cold outside. It's a reflex vasoconstriction. So you want to measure a toe pressure with the patient warm. You're going to allow a little bit for the room to be cold. So we can say the toe pressure can be a little lower. So a toe BI is considered abnormal if it's less than 0.70. Exercise ABI I talked about already. That's what we're going to do if we think someone has PAD, but the resting ABI was normal. So how do you diagnose PAD? We have a couple choices: toe brachial index, pulse volume recording, ABI, exercise ABI, or all of them. And the answer is all of them. So we have many opportunities. We're going to have a good clinical sense of who we're dealing with, and we have testing. One of the big issues, and it's come up with United States Preventive Services Task Force and others, is this concept that's been out in the medical literature for a long time of asymptomatic PAD. So one of the big issues is many people do not have symptoms because they are not walking. And ESC actually did a very specific and straightforward introduction of this with the concept of masked PAD. And people that were deemed asymptomatic in many of these studies, many of them are in Europe and many in Northern Africa. And I would have thought that walking would be more there. But in one study in particular, 1/3 of the people who were deemed to be asymptomatic only walked 6 blocks at the most at a time. Many people were only walking 1 to 2 blocks as a routine. So it's hard to actually identify that they have these exertional muscle problems if they're not actually walking to generate increased demand in the muscles. And the other issue, potentially more important to me here and probably to you there, are the elderly patients with multiple comorbidities who don't walk. Bad heart failure, housebound for other reasons. They get toe necrosis after just a trivial podiatry intervention. It turns out they have bad PAD. So I think one key point is heightening our antenna, actually examining patients' pulses, understanding that they're not going to tell us about pain if they don't walk. And I think that it becomes more important with specific populations. So who do we want to look at? Some people, like many of my colleagues, I'm just resting on this picture because they say, listen, atherosclerosis is everywhere. I'm a cardiologist. If I'm treating them for atherosclerosis in their heart, I don't know that I'm going to make any other difference by recognizing it in their legs. So why diagnose it? The United States Preventative Services Task Force says, I don't think you should diagnose this because then people are going to go do interventions that the patient doesn't need, and it's going to be harmful. But there are things we can do if we make a diagnosis. People with PAD have poor functional capacity. They actually have abnormal calf muscle architecture at risk. So they have a disease, and we do have therapies. So there's been a lot of pushback from many of my colleagues. Josh Beckman is still pushing back to the United States Preventative Services Task Force. And they were mostly thinking about identifying abnormal ABI as a risk factor. And really what we're talking about is diagnosing disease. So if you have an abnormal ABI, this is the 70s and the 80s, looking at people over 10 to 12 years. People that were called asymptomatic PAD had substantial risk of mortality. Well, that's a long time ago. What about now? So now, even if you pool all these studies, I've got symptomatics and asymptomatics in here as well. Majority asymptomatics, there's still a threefold increase in mortality once you've diagnosed someone as having PAD. So we are recognizing this population with higher mortality. I think it's incredibly striking that colleagues that have done calf muscle biopsies in people with PAD have identified abnormal calf muscle architecture in people with absolutely no symptoms that they could detect. So the impaired flow is resulting in a physical disease in these patients. And it's really quite striking to me. The functional status is impressive too, because you think it's just a little bit of a decline in the pressure going to the lower extremities, so a little bit of accumulation along the pipes to the lower extremities causing stenosis. But even when you start with a multi-ethnic population of healthy, middle-aged, community living men and women, those with an ABI just under 0.90 had significant decline in functional status over the 10 years. So what does an ABI less than 0.89 mean? They have PAD. They have poor functional capacity. They have increased mortality. They have it all. So what are we going to do that's specific to PAD? I think my slides are a little out of order, so you're going to bear with me for a minute. The guideline-directed medical therapy that applies to cardiac athero applies to PAD as well, but we're going to focus on exercise, blood pressure control, and antithrombotics here, and thinking about when to intervene. Exercise is hugely important. We know it's important for cardiovascular disease as well. And this is just taking all people with PAD. The advantage of exercise decreases cardiovascular events, and it's going to decrease physical disability. So this has been shown in a number of studies, many of which you're familiar with, that looked at iliac interventions and exercise as well. Supervised exercise training programs are paid for now, but any exercise that you get a patient to do on a daily basis is going to help. Walk till it's uncomfortable, rest, start walking again. Our goal is just like our goal for the heart, that we want people to walk ideally for 30 minutes at a time. So now thinking about that housebound elderly person who can't walk, what do we have? And we have arm ergometry. And since I was doing virtual clinic in my office this morning, I have a demonstration for you. So for arm ergometry, it's just a desktop cycle. Many people don't have a desktop cycle. It's literally just cycling with something they get from CVS or with just a bottle of water. And again, the idea is to slowly build up to 30 minutes a day. The significant thing is that there have been a lot of data accumulating that cycling, daily cycling with your arms is going to improve outcomes. increase in walking distance was shown first, and now there's data showing that there may be an increase in survival. So that's pretty huge. And the idea is any activity is good activity. And this is just over the top good activity. So if you take people's baseline fitness and improve fitness, here in this bottom corner, we have people with the best baseline and the most improvement, and they have the best survival. It was just one study that put it all together in terms of multiple populations of patients. But it's pretty powerful to say, we just need to help people get active. In terms of unique therapies with PAD, we have cilostazol, which was approved before we had a lot of data. We know that it's got a black box warning for people with heart failure. We don't know exactly how it works, but if it's going to work, it'll work in the first month. If it doesn't work to improve walking distance, it's not going to work. We also have pentoxifylline, and we have many studies that show it doesn't work. So although it's very popular, I think we can drop that one. Anti-platelet therapy is much more of a moving target. We need anti-platelet therapy, but which one should it be? So aspirin, clopidogrel, DAPT, Vorpaxar, they've all been candidates. I think some of the best data has been for Vorpaxar, to be honest. But there's certainly data for clopidogrel, and there's certainly data for aspirin in symptomatic patients. In addition to that, what's getting a lot of press, and I recognize much of it is probably from the company itself, is the role of anticoagulation in addition to antiplatelet. And this is using the lower dose rivaroxaban. And there are many publications on a small set of data, but over and over we see that the combination of rivaroxaban but plus aspirin decreases both cardiovascular events, but importantly for us, in people with PAD, it decreases limb events, including amputation. And these included asymptomatic PAD, so people with PAD of 0.90 where no one had really recognized symptoms in them as well. So it has a lot of power for us. Clinically, the one that I think stops people all the time is blood pressure. They know that there's a problem treating blood pressure, and it may be more complicated in PAD. We think ACE and ARB is probably the best therapy. There's not a lot of data to support that, but the data that we do have says that. But the thing that people are encountering is that when you lower the central blood pressure, you're also going to lower the pressure across the stenosis in the leg. So people may have more claudication. They may develop disabling claudication. But as cardiovascular docs, we know we have to reach target blood pressure. So that's our first goal. And then if we have to deal with disabling claudication, we have to. And if it's really disabling claudication, we are going to be thinking about what the right thing to do is for the patient. This can be endovascular or surgical. And it's really going to be those patients with a lot of comorbidities, without veins for access, maybe we've used a lot for the heart already, will favor endovascular. People with poor outflow, single artery outflow, or a lot of a disease in the groin would favor surgery. But this is going to be individual, and it'll be guided by urgency. And there are times when you're actually going to end up doing both endovascular and surgical revascularization in a patient. So the patient, what do they worry about? Well, since many of them weren't walking in the first place, they didn't notice that they can't really walk, so that might not have bothered them. The thing that bothers the patients is the risk of amputation. It's actually generally a pretty low risk, but that is the concern for the patient. And it's not the same for everybody. So we're going to talk about that a little bit. The good news is that angiography on the top and resulting endovascular interventions and surgical bypass have been increasing in total volume over time, with a shift to endovascular interventions taking place. The concern is that this has not translated, oops, I need to go back. Well, this has not translated to decrease in amputation for everybody. So who is it not helping as much? Well, one group are the people with microvascular disease. So excess cigarette smoking, the multiple packs a day of cigarettes, diabetes are the big ones for this. The next thing is, whoopsie, how do I go backwards? The next thing is race and socioeconomic status. So I must say that this was more apparent in the publications in Europe before here. But the amputation risk was definitely 8 to 10-fold higher in elderly patients and in patients with darker pigmentation, multiple continents, very striking. And I must say that I actually assumed that if someone had limb ischemia at rest, so we can barely detect a pulse, they have a cold foot, that they're going to get some technique to look for arterial disease before an amputation. I found out that's not actually true, unfortunately. And this is the most inflammatory of the publications here in the United States now, but this is actually data that shows up in multiple publications and is true. The amputation rates are much higher here in the deep south parts of Southern California, but the maps in the deep south are way too coincident with enslaved populations in 1860. And if you dive into this in many ways, it turns out that these are people with very dark skin. There's a little higher proportion of diabetes, but it's actually the dark skin that's driving most of this. The question is why? I don't know that we have the answer. I'm a little bit of I like to look for the best in people. So part of it, I think, and I thought about it for years, is our difficulty with recognizing PAD based on skin color. This is just from something I use with the medical students, because a lot of us learned all of our peripheral vascular exam skills with respect to lily white skin. And that is not our population. So things look a little different. So things like dependent rubor and elevation pallor are going to look different. And you can see how much more subtle the rubor example is in these models with different color skin. So clinically, this became important to us during the pandemic. A lot of this starts in March with all the discussion about COVID toes and COVID blue toes. I was getting like a picture an hour for a while. But in general, the COVID blue toes concept is very similar to pneumonia-triggered triad. And I documented this years ago in a population of patients where, and it turned out and we found a genetic disease that explained it in their particular case. It was a complement defect. But whenever anyone got a pneumonia, even a mild pneumonia or upper respiratory infection, they would show up with pernio and with very profound, well-demarcated vasospasm in their toes. It's very similar to what we're seeing here. So the pernio lesions, older people like me are probably used to seeing them on shins and on toes for a long time, and people that in the north are used to seeing it. But they're red to red-violet, flat, circular lesions. They can blister. There's some pain and itching. We used to see them more frequently in response to cold injury. Girls not wearing pants in the winter kind of thing. But I think the most clinically important thing that's become evident to me is the patient's description of this sudden stabbing pain. And you're going to see, hopefully I kept them in here, but some of the examples with people with darker skin, the lesions are less obvious, but the description of pain is always spot on. The episodic digital vasospasm, I'll show you pictures, but it is very profound, usually relieved with warming, and unfortunately harder to recognize in darker skin. And if other things are going on, like their big stretched out heart, or they're on a ventilator for their lungs, people may not be picking it up. The livido also, transient livido that blanches is part of this. It is harder to recognize in darker skin. I'm saying this as a woman sitting here with very pale skin. And so I have a bunch of these cases, and many of them Esther Freeman has included in her publications on this, but I just included a couple examples. And I think this is important for us with the unit patients too. They can't speak to us, they're on a ventilator. You can see their toes, but we can also look at the toes with the pulse ox that we use for the fingers. If we look at the waveform, not just the number, we can see that the quality of the arterial flow going to the toe. So this guy, well demarcated color change here on toes 3 and 4. They're a little blue. This lesion here kind of looked like a blister, but his description is spot on for this sudden burning discomfort, and it itches a little bit. It's a pernio-like lesion. You can barely, he's got darker skin. This is an Asian gentleman. He's got transient livido that you can barely see even in him. So he has this triad. So this is COVID blue toes with darker skin, and therapy was incredibly simple. Warming, and we had trouble with pressure, so we had to use fluoxetine, which we often use for vasospasm because it works on the alpha-2C adrenergic receptors very well. And within 2 weeks, he had vast improvement. So those are the same toes. And in contrast, while evaluating him, we're seeing something very different in our patients with dark skin. We're seeing people, I was getting called with this presentation. This person had some clearly gangrenous toes, did have some vasospasm on the second toe that improved with warming. The well-demarcated pallor went away, her waveform improved, but she actually had tissue death because of the amount of vasospasm that had progressed in the other toes. The sad thing is that many of the nursing notes had reflected this, but it was just, there were so many other things to take care of. Unfortunately, on the other foot, it was almost all toes. So this changes her life. Like, we got her through this. She also had a stroke. We got her through that, but she's losing her toes, and actually the forefoot on the other foot. So that spurred us on to do an educational campaign, and we did a lot better. By summer, we're doing a lot better now in terms of recognizing livido and darker skin, just a lacy pattern that blanches. Vasospasm, you're just looking for the demarcation. And in really dark skin, it's often easier to see on the bottom of the feet rather than on the top. And we really put a lot of weight on the description of that burning, itching discomfort when we see the pernio lesions, which I appear to have taken out of this. Now, to the thrombosis. We have all lived through this tsunami of COVID-19 papers on thrombosis. So I'm going to try, these are points that I put together at about the 3.5 million mark with these patients. So there are a couple of points that are clear, that we've got decreased mortality with heparin prophylaxis. The rates are high. In our own publication, it was almost 18%, but definitely high. So VT rates at 11% versus 2% in many controls. So prophylactic doses have been increased here. We're thinking 1/2 therapeutic dose. So that's prophylaxis. So if we have a problem, a DVT or a PE, we're using the same clinical doses that we would use otherwise. The ICU, as you know, has been very difficult. if taken together, we presume PE, then it's therapeutic anticoagulation. Difficult to make a diagnosis. So I think the only place where we've really escalated the doses of prophylaxis have really been in the ICU. Everyone else is going to get about the same therapy they got before, with the exception of more frequent presumptive PE and full dose anticoagulation. Oh, and the other thing that's come up that's really more and more clear to me is issues of limb ischemia. So this case, like everyone else, we had to jump in, put a publication out, but this is acute limb ischemia with acute arterial thrombosis. So we're seeing thrombosis, DVT, dialysis catheters. We were seeing strokes. And the lines clot like crazy. So upping your prophylaxis to prevent that, and then full dose therapy. We've seen a few too many of these acute arterial thromboses. So this woman, 70-year-old woman with diabetes, hypertension, she actually came to the hospital with the cold pulseless leg, modeling a pallor to the level of the calf. So cold and pallor in a distribution of vascular territory, acute limb ischemia, no pulses on the left side actually, and pulses on the right. She had severe respiratory distress and was SARS-CoV-2. So at that time, we do just have to deal with the fact that she has a cold leg and try to save it. So she got angiography. The question of whether there was absolutely no pulse or a little bit of a pulse is difficult, but with Doppler, you could hear a little something at the ankle. So we went, and this is actually the reconstructed CT. There was an acute occlusion, and she ended up getting, hopefully I put it in there, or maybe not. I'll go back to that. She's getting therapy. But I just wanted to walk through clinically what we're doing. So an acutely cold, painful leg. She has a little bit of sensory loss. She does still have motor function, and she has some kind of signal. So it's completely viable if we can hear arterial and venous signal. As is pointed out to me, I may be the only person around that detects the difference between arterial and venous signals. So I just want to say, if you hear anything, it's going to be viable. And it may just be the venous signal. The difficulty in how fast you have to act at that point is depending on capillary refill, dramatic sensory loss that starts progressing beyond the toes, and any sign of muscle weakness. And you're urgently going to start with some imaging technique. Angiography is a great way to start because you have something you can use for revascularization should you need it at the same time. And I think, again, the key is really, really need to act fast if you have any sign of muscle weakness and sensory loss. So she had emergent thrombectomy and thrombolysis. She ended up needing a fasciotomy because everything probably took a little bit too long, and she had a little bit of compartment syndrome. She actually, she was able to walk out of the hospital. She went out on warfarin. I just saw her months later. She's actually doing quite well. Since that time, we've seen more than a couple other people with accelerated PAD, extremely accelerated PAD. So no hint of much of anything a year ago to ABIs of like 0.0 now. Imaging showing a lot of atherothrombosis. So again, they're going to get standard therapy for revascularization. The last 5 that we've seen have all been COVID SARS-2 positives, COVID-2 SARS positive. And this is happening after acute infection. So not the initial presentation with the cold leg, but in the recovery phase. coming in with near critical limb ischemia. So we're going to be looking at that hopefully through this EHR-based network. And it's going to be the best we can do for now. So in addition to what people are coding, we are going to have good chart review and adjudication of all events, and hopefully start understanding what's going on. It's very clear that amputation rates are actually rising in the pandemic era, and whether that's from the initial under recognition and under treatment in people with different socioeconomic status and darker skin, or whether it's related to the infection itself, we're not going to know. But we just need to keep our antenna up. And with that, I want to say, together we can do this. We keep legs healthy. We keep people walking. We keep hearts and brains happier. Things have changed over time, but we can do this. And with that, I am happy to take questions.
Thank you, Marie, for a very comprehensive and thought-provoking presentation. I was mesmerized by some of the images that you were showing. Particularly, I like to see the changes in the COVID patients with the normal nails, which is something that you don't see on the classic PAD patients. So that is almost very posed for a board question right there.
Yeah, it's really impressive.
How do you differentiate the ischemic events caused by COVID particularly in the digits from the changes induced by vasoconstrictors that are used very commonly in some of these patients when they go to the intensive care unit?
Oh, that's huge.
Yeah.
Yeah, so when you go to the intensive care unit and you're on your pressors, the vasoconstriction is usually all digits. Particularly in some of those women that we were seeing early on, if you look through the record, they were just having vasoconstriction in one or some of the digits, and all of them had these funny lesions as well. These little, they look like little violet circles that were probably pernio if they'd been able to talk. And the key is that unlike pressor vasoconstriction, this digital vasoconstriction is easier to relieve just by warm blankets. So if you have a blanket warmer, just wrapping the feet with a blanket warmer, if you use bear huggers, using that, actually pretty impressive. But if it's not totally uniform across all the nails, across all the toes, your antenna should definitely be up.
And do you see any correlation between these peripheral vascular events and elevation on biomarkers?
We're going to look at that. So for the acute limb ischemia patients, biomarkers were up, but I don't know what to do with that because they had acute limb ischemia. So we're collecting data on the people that are in the downside of COVID, PAD presentations with critical limb ischemia. Many of them do have pretty high inflammatory markers. And on imaging, we haven't figured out how we're going to do it yet, but their occlusive disease looks more thrombotic, specifically thinking of CT imaging.
Just to remind those that are connected, you can ask questions using the Q&A or the chat function on Zoom if you have any additional question. Maybe I'll ask you another one in the meantime. You did not talk a little bit about the differentiation of claudication and pseudo-claudication, and certainly it's not uncommon for us to be convinced that someone has classic peripheral vascular disease to find out that the studies are completely normal and they do have spinal stenosis. Do you have any clue?
Yeah. So the clue is that do they stop walking and it gets better, or do they have to sit and stretch the spine to make it better? And you're always going to run across the person who has both. So in the person that has both, you can also look at what happens to their ABI when they walk on a treadmill if it drops more. But if they have to actually sit to make it go away, it's going to be spinal stenosis. And the pain is going to be more down the lateral aspects of the legs. But that's a frequent one.
So there's a question from one of our fellows here, which I think is a good question. I'm going to extend it. He asked, what is the evidence for full dose anticoagulation on admitted patients with COVID-19 who have no evidence of PE or DVT? And I want to extend it to you. How about in those who are not admitted, who are at home and have, let's say, moderate symptoms?
We don't have enough data for full dose in everybody that comes in. So I think we have accumulating data on increasing the level of prophylaxis potentially, but not for full dose. And what the heck do we do in those people that don't come to the hospital? We don't have enough data yet. But I don't know about you guys, but it appears this time, I don't know how many people we're going to see, but if we have a lot of people that are going to go home, that are people that we might have kept at the hospital before, I would be thinking about at least a few weeks of prophylaxis. No data.
I mean, one of our interventional cardiologists here, Dr. Manigos, wants to ask you a question here. He does a quick and dirty ABI in the office with a blood pressure cuff using the higher arm and the lower leg. Is that sufficient as a screen? I guess he's not doing.
It actually is. So we looked at that in the partner study years ago in multiple settings, from the homeless shelters to high-end practices out in the suburbs across the United States. And it was a very valid ABI. The way you look at ABI, it's interesting that comes from an interventional cardiologist, because there's two ways to look at the ABI, because you can do a Doppler and use the higher of the two ankle pressures, which is what they've done epidemiologically. But it may be more valid to find the PAD to use the lower of the two. And if you use an automated cuff, you're only going to get one value anyway. So although it's quick and dirty, I think it's a valid ABI.
Sure. So I have Dr. Wiley here, who's an interventionalist in Peripherally.
Hi, how are you?
Hi.
It's a pleasure. Quick question. As an interventionalist, I'm always looking for therapeutic modalities for patients that come with lifestyle-limiting claudications that are unresponsive to supervised exercise and cilostazole. And for a number of years, we were using plain old balloon angioplasties, then bare metal or nitinol stents. And more recently, we started using drug-coated technology. And as you may be aware, a couple of years ago, a large meta-analysis from a group in Greece came out, and it dampened the entire enthusiasm of using drug-coated technology to a point that the FDA got involved.
Yeah.
And made a warning. And the question is, should we be holding off on that until we have more data? There's been a few patient-level meta-analysis, but they're not that robust. There have been small patient-level meta-analysis that may adjudicate causality. But what should we doing? We should be doing now, other than consenting our patients about a possible increase in mortality, which is what that.
So for the near future, we're going to hold on drug-coated, but there is data that's coming out. Hopefully, for God's sake, hopefully within the next few months. Substantial data. So hopefully that will help us. And then I guess the other thing is that we really need to hammer on the lifestyle part. So the supervised programs, I don't know what you guys have there, but it's incredibly hard. I'm glad that we can get paid for them now. But once the patient gets in, they're only in for a short time. It's kind of like cardiac rehab. So we have to give them ways to do exercise in daily life that they're just going to keep doing. So it's not like they're going to exercise for a week and it's going to last forever, because it's not. So I think we hit with both.
And there's modify one question placed by Dr. Monra here. Part of the question was already answered, but he's asking whether um, you have any data or any experience on use of calcium channel blockers to prevent or to treat vasospasm on the COVID patient
Oh,
or nitrates, I guess.
no, that's actually good. So that's good on many levels. So it's perfectly reasonable to use a calcium channel blocker for digital vasospasm. In this triad that we've seen before with respiratory infection, libido, pernio, and the digital vasospasm, actually the alpha adrenergic blockers have worked even better than nifedipine. Nifedipine is possible, and fluoxetine has worked. So I think it's digital vasospasm. You're going to treat it the same no matter what caused it. Nifedipine and warming is a fine place to start. I think the issue with a lot of these patients coming in is they already have a pretty marginal blood pressure. And that limits us.
Great. Marie, it was a great presentation. I think is very appropriate. We are preparing here for a possible second wave. I mean, we have a small wave going on right now. We don't know how bigger it will get.
We just made one of our cardiology teams a COVID team, so.
Well, we were discussing earlier with our fellows today how they are going to be potentially taking over also a COVID team. We did quite a few of those in the first wave, so we're used to. But it was a great pleasure to have you here. We'll have you available if we have any blue toast or white toast or colors that are, I guess, inappropriate in general. We will call you.
Someday I'd like to see you guys in person, but I'm glad I got to meet you.
I hope so very much.
Thanks, you guys.
Bye-bye.